Ultrasound Physics and Function. The videos on this series can be accessed at ultrasoundredgoo.com, or you can go to YouTube and search for the channel Ultrasound Red Goo. Feel free to subscribe as I upload new content regularly. Here's a quick look at the lab that produced these videos. The human ear hears a range between 20 Hz and 20 kHz. Diagnostic sonography utilizes a range between 1 and 20 MHz. The velocity of a given tissue is fixed and not affected by the frequency or wavelength of the pulse. This graphic demonstrates where ultrasound lies on the acoustic spectrum. Like light, sound is produced in wavelengths. The lower the frequency, the longer the wavelength. Here we see the upstroke or compression, and the downslope is the rarefaction of the wavelength. Here we see a waveform with compression and rarefaction. The lower the frequency, the longer the wavelength. Also, please keep in mind that ultrasound waves are considered longitudinal waves as opposed to transverse waves. Frequency is the number of cycles in a second. Frequency is inversely related to the period or duration of a cycle. 1 cycle is a hertz. A kilohertz is 1,000 cycles per second, and therefore a megahertz is 1,000,000 cycles per second. Basic physics. Transverse plane, or the axial plane, runs parallel to the ground and separates the head from the feet. The sagittal plane is perpendicular to the ground and separates right from left. The coronal plane separates anterior from posterior, front from the back. The oblique plane is in between transverse and sagittal plane on an angle. The beam of sound interacts with the object based on its trajectory. This trajectory is created by the probe's angle of incidence. The ideal angle of incidence is 90 degrees or straight on. Most objects in the human body have anisotropy. This implies that they are directionally dependent. Knowledge of how the ultrasound beam is interacting with the desired object is important because of this. The playground ball on the left has isotropy. No matter which way you look at it, it looks like a playground ball. On the right, we see the brachial plexus. This has anisotropy. It only looks like the brachial plexus from one direction. Keep in mind your angle of incidence and how you are viewing the picture. Parallax will come into play, especially when placing a neckline. This slide here shows parallax. Here we see viewpoint A on the left side of the graphic. Viewpoint A looks at a star and sees it on a blue background. Viewpoint B looks at the same star and they see it on a red background. And this is because there's parallax or a different viewpoint. The same could be on the speedometer or gas gauge of a car, where your view at 90-degree angle or directly on is much different than your spouse's view or shotgun rider. Now this is important when inserting a neckline because typically we're looking over the right IJ from the left side of the patient. So as we're looking at this on a probe that's on about a 30-degree angle, we notice that the needle does not appear to approximate to the vein, even though we appear to have everything lined up. A way I mitigate this is I left bank the patient or left tilt them on the operating room table. Reflection occurs when two areas of different impedance interface. This is also known as backscatter. The strength of reflection depends on the difference in acoustic impedance, size, surface interface, and orientation to the probe. The difference, not the amount of reflection, is what creates the ultrasound image. This is different than more familiar imaging techniques such as X-ray, which rely on penetration. In an X-ray, we see that the dense structures such as bone are white. Less dense areas such as parenchyma and air are dark. Note that ultrasound works by change, not by density. Absorption. Sound energy is absorbed by tissue and converted to heat. Heat can be generated by the ultrasound beam. However, more important is the ability to cause cavitation of small gas bubbles, resulting in tissue and nervous injury. Because of this, limits are set. If you care, 100 milliwatts per centimeter squared for a focused beam is the limit. 1 watt per centimeter squared for an unfocused beam, and 720 watts per centimeter squared for a cardiac ultrasound are the limits set. To date, no injury has ever been confirmed from ultrasound use. Scattering. Not all echoes are going to go back to the probe. Some will scatter in all directions, especially from objects smaller than the wavelength and with rough surfaces. Here we see scattering from the irregular surfaces of a fetal femur. We also see scattering from the placental parenchyma. The denser the tissue, the faster the sound travels. Ultrasound travels slowest in gas, faster in fluid, and even faster in soft tissue, and the fastest in bone. The assumed soft tissue propagation velocity is going to be 1,540 meters per second. The reason this speed is important is because the return time of the sound is how depth is measured. The ultrasound machine hears the echo from this sound wave and processes an image. The machine will transmit a sound roughly 1% of the time and listen 99% of the time. The pulse length ranges from 2 to 3 cycles in pulse echo imaging and 5 to 30 cycles in pulse Doppler ultrasound. The amount of time that the piezoelectric crystals resonates for is conveniently referred to as the ring down time. Areas that reflect back strong sound signals appear white and are referred to as hyperechoic. Areas that are poor reflectors create dark or black areas referred to as hypo or anechoic. This is accomplished through piezoelectric crystals. These crystals are stimulated by electrical current and produce a sound wave. They are also deformed when the wave is sent back to the crystal. Each crystal has a wire, and this helps account for the high cost and fragile nature of ultrasound probes. This slide is going to sum up the high price of probes. There is a lot going on inside these guys. If we look at the probe on the upper right hand side, this is about a 24 to 50 element probe. This is a prototype of a very early machine. The average linear array currently has 256 piezoelectric crystals, each with its own wire. The beam has two planes of resolution. Resolution is the ability to differentiate two different reflectors as separate structures. There's the axial resolution, lateral resolution, and temporal or resolution over time. What is resolution? It's the ability to separate 2 points or resolve them. Here we see area diffraction patterns generated by light. Points closer than the Rayleigh criterion are seen at the bottom and cannot be resolved. Although this is an example of light, resolution, and a good analogy to remember is that resolution works on the same principles whether it's light or sound. Lateral resolution is the ability to resolve 2 or more objects perpendicular to the ultrasound beam. Axial or longitudinal resolution is the ability of the probe to resolve 2 or more objects parallel to the beam. Temporal resolution is the ability to resolve a moving object. In the case of ultrasound, the probe may be the moving object, or the patient's beating heart may be the object. In the video to the right, we see the hummingbird's wings flapping, but we don't see each flap of the wings because it's faster than the frame rate of the camera. When an object or probe is in motion, less resolution will yield a better picture. Move the probe slowly when good resolution is desirable. Remember in an emergency that slow is fast. Use the shallowest depth possible that will yield a safe result without using the zoom. It's always going to be a trade-off between spatial resolution and temporal resolution. The less tissue that is penetrated, the better the resolution. If a gas pocket or very dense tissue is scanned through, poor image quality will result distal to that object. An example here is when attempted to scan through the lung tissue during a TTE or TEE. Structures past that gas-filled structure become non-viewable to ultrasound. Resolution itself does not equal superior imaging quality. The higher the probe frequency, the greater the resolution. This occurs at a cost of penetration. Therefore, image quality of deeper structures is better with a lower frequency probe. The liver seen here is being scanned with a high frequency curved probe. Now the liver seen through a lower frequency phased probe is noted. Note the better detail in the far field, and we can see pathology going on at about 6 o'clock at the bottom of the far field. The anatomy of the beam looks like an hourglass. Near field is referred to as the Fresnel zone. Far field is also known as the Fraunhofer zone. A single crystal transmits a semi-spherical beam. When placed in an array, the beam takes on the characteristics of an hourglass shape due to the constructive and deconstructive interference. This is known as Huygens principle. Here we see the near field and the far field with two focal zones noted. The beam is broken down into lateral or azimuth, axial or depth, and elevation, which is typically less than 1 millimeter. This is also known as slice thickness. One function of the probe is referred to as frame compounding. In frame compounding, the probe takes the images from different angles and makes an average. The result is increased spatial resolution with decreased frame rate and decrease in temporal resolution. This is an example of frame compounding, and although it's difficult for a proceduralist to notice, the image all the way to the right is of much higher resolution. The crystals are arranged in shapes or arrays. Each array type has its benefits. Various probes exist. Here is a breakdown of their common uses in anesthesia practice. Knowledge of each type is important and it can enhance your clinical ability. Know your limits of what you know and what you don't know, and consult a specialist when practical. Probes come in a variety of types with various uses, strengths, and weaknesses. To the left, we see a curved probe. In the middle, we see a phase array probe. And on the right-hand side, we see our standard linear array probe. In the linear array probe, 64 to 256 elements are present and work in groups. This gives a high-resolution picture with low penetration. This is great for vascular access and most regional anesthesia. Various footprints are available. Narrow to wide sizes are available and each have their own benefits. These produce a square picture. Frequencies range from the common 7 MHz probe to 16 MHz high-resolution probe. This is the square sonogram common with a linear array probe. Uses in anesthesia include vascular cannulation, arterial cannulation, Palmar arch assessment, regional anesthesia, and assessment of central line and indwelling catheters placed by other providers. The curvilinear probe or curved probe is one of the most utilized probe types in medicine. Frequently encountered at the OB/GYN office, they have many uses. The rounded probe offers reasonable resolution with deep penetration. The drawback can be a large footprint which can require the application of pressure. This probe produces a blunt sector-shaped image on the screen. Pressure is often needed to ensure gel-skin interface. This is the blunted sector picture produced by a curved ultrasound probe. The curved probe. Uses in anesthesia include regional anesthesia including sciatic and tap blocks. This probe can be useful for adductor canal blocks as well. Real-time neuraxial techniques can utilize this probe, as well as examination of the abdomen for fast antral and bladder scanning of the patient. Phase array probes have high penetration and low resolution. They are often utilized in cardiology and have excellent temporal resolution. Their small footprint is useful for scanning in between ribs. These probes produce a sector display. A phase array picture with sector display. After being received, the sound is processed into an image. Images and clips can be stored and processed further to interrogate the clinical picture. Processing techniques such as frame compounding, tissue harmonics, and speckle reduction help improve the raw picture. Modes range from single crystal displays on an oscilloscope to array-driven panoramas with 256 shades of gray. B mode or two-dimensional mode is the most common in anesthesia. Named B for brightness, it produces a flat picture. How a B mode picture is generated. Numerous shades of gray are produced based on impedance. The most common mode of the ultrasound machine used in anesthesia is the B mode. B standing for brightness gives the user a real-time two-dimensional picture. M mode or motion mode is useful for measurements of boundaries such as vessels. M mode uses one crystal to send impulses. There are also Doppler modes. The first one is color Doppler, which color Doppler velocity is shown over the 2D image. This can be shown as a velocity map or a variance color map. 2, we have continuous wave Doppler. This uses two crystals to continuously hear and collect data. 3, we have a pulse wave Doppler. This uses only one crystal. It's very useful for clot detection in TEE. 4, we have the power Doppler. Power Doppler is used for low flow and small vessels. Now, unlike color Doppler, it does not show the direction, it looks at the amplitude of flow. This is used for vascular emergency and testicular torsion. Frequently, Doppler modes are duplexed or triplexed with 2D pictures and EKG traces. Other modes exist. A scans give one-dimension information. These scans measure distance but do not create an image. They are often used in ophthalmology. A stands for amplitude. 3D ultrasound also exists, useful for fetal imaging and cardiac TEE modeling. The X, Y, and Z or Z axis are rendered. When the scan is rendered in real time, the scan is referred to as 4D. I must go on to saying that 4D interrogation of cardiac valves absolutely rules. This technology uses 2,000 to 3,000 crystals in a 2D phased array. Tissue harmonic imaging. This will also reduce noise in the signal and can be used to enhance the picture. This can be accomplished by a low-pass filter or a subtraction filter. As with any increased resolution technique, this may impair the temporal resolution. Color Doppler gives a picture in red and blue tones. Frequently mistaken as a label for arteries and veins, the colors used have a different purpose. These colors represent the direction of flow in relationship to the probe. For color Doppler, remember BART. Blue away, red towards the probe. Therefore, if the probe is perpendicular to the vessel, the data becomes less useful. As with any imaging or electronic device, the ultrasound image is prone to artifact. Artifacts must be understood to determine what is relevant in the image viewed. As ultrasound machines improve, artifacts are less common. Due to the nature of imaging, artifacts will never be extinct. The main artifacts to consider are posterior wall enhancement, shadowing, refraction, reverberation, and ring down. Posterior wall enhancement. This is seen when the beam passes through an area with low attenuation. The beam then contacts an area with higher than expected attenuation and a bright hyperechoic area is seen. Posterior wall enhancement is an artifact of attenuation. The beam goes through an area of weak attenuation and produces a hypoechoic picture. The beam then contacts an area with more attenuation and falsely makes it more echoic or bright because it did not expect it to be attenuating. Note the areas of brightness underneath the hypoechoic fluid. Shadowing. Shadowing occurs when the ultrasound beam encounters a strongly attenuating object. The beam returning from under the strong attenuator is low compared to the surrounding tissue. The result is a hypoechoic or anechoic area underneath the strong attenuator. This can be a useful artifact to tell whether or not an object is really there. A very dense object with a shadow underneath it. Shadowing is an attenuation error. Here we see a gallstone. Refraction. Refraction is an error of velocity. It occurs as the beam passes through two objects with different density. It is dependent on the beam incidence. The beam is then refracted to the side. The processor of the machine assumes the beam is straight and places it erroneously on the screen in the wrong place. The amount of directional change in the beam is a function of Snell's law. This is an example of Snell's law, and here funny O is angle, so O1 is theta I, or angle of incidence, O2 is theta R, or the angle of refraction, N is the index of refraction of the incidence and refractive mediums, and lambda is the velocity of the sound or light. There will be multiple test questions on this slide. I am totally kidding about that. Reverberation. Reverberation occurs when two highly reflective surfaces are parallel to the beam. The beam is constantly reflected back to the probe. Since the depth of an object is determined by the time, the object is imaged deeper and deeper into the far field. So the object on the top is the correct object. Now with reverberation, we see multiple needles here. So frequently reverberation is caused by a needle because it bounces off of first the uppermost part of the needle and then the bottom part of the lumen of the needle. Ring down. This artifact occurs when small crystals or air bubbles resonate at the frequency of ultrasound. These sounds are received after the initial ultrasound signal. Since more time has passed, the ultrasound machine processes the image as being deeper in the far field. Ring down artifact. This artifact can be useful to tell if a space is occupied by gas, such as an abscess. But just FYI, there is debate between whether an artifact is ringed down, typically caused by gas creating its own resonance, or a comet tail, which is caused by a hard item such as metal, causing the sound to reverberate. Safety. The amplitude of the wave is the maximum variation generated by the ultrasound beam. The pressure amplitude is directly related to the amount of sound energy emitted. The measures used in diagnostic ultrasound are power and intensity. Power is the flow of ultrasonic energy through the cross-sectional area of the beam. Intensity is the power divided by the beam's cross-sectional area. This is measured in milliwatts per square centimeter. As stated previously, machines after 1976 are limited in their output. The center of the beam, or the focal area, has the most power. Diagnostic ultrasound has been in use since the late 1950s. There are no confirmed adverse biological effects on patients resulting from this usage. There are AIUM safety and training and research statements from 2012. Guidelines for training on live subjects are available at AIUM. First trimester exams should be avoided when reasonable, and always remember to institute a LARA, or as low as reasonably achievable. Understanding the basic physics of ultrasound can have utility in the clinical setting. Continue learning new techniques in ultrasound, and don't let ultrasound just be blocks and lines. Rather, use ultrasound as a valuable and available tool. This is a list of my references.